Okay, I think we can start now. Dr. Yati, Dr. Syakirin, are we okay? Yeah, okay. Good afternoon, everyone. Welcome to our weekly webinars. This week we are starting with Respi, first week of 3 more weeks to go. I am Dr. Mina from Taiping Hospital. We have a great privilege today to have a very important person from IPR, Dr. Nurhayati, to chair today's session. Without further ado, I'll pass the floor to Dr. Yati. Dr.
Thank
Yati,
you very
please.
much. Thank you very much, Dr. Mina. Right. Good afternoon, everyone. Welcome to College of Physicians Malaysia Respiratory Medicine webinar May 2021. So to start the webinar in May, for the first session, we will have the topic post-COVID-19 syndrome and respiratory sequelae delivered by Dr. Syakirin. Dr. Syazatul Syakirin graduated from UKM in 2003 and subsequently obtained her MRCP in 2010. Since 2012, she was actually trained in respiratory and she had her ILD training in Foley, yeah, with Professor Folati over there. So I would like to welcome Dr. Syakirin to deliver her talk today. Please, Dr. Syakirin.
Thank you, Dr. Yati, for the kind introduction. I'm going to share my slide now. Okay. I'm going to talk about on post-COVID-19 syndrome and the respiratory sequelae. And these are my outline of lectures. So I'll be talking a brief overview on SARS-CoV-2. How and what does SARS-CoV-2 actually happen, or what does it do during acute phase? What is the impact of COVID-19 on the respiratory system? And what do we know about the long-term effect of COVID-19 and the long-term follow-up for COVID-19, post-COVID-19, especially for respiratory sequelae? So these are the key events in the early coronavirus disease pandemic. So in December 31st, China actually first alert WHO there's a cluster of cases of pneumonia with unknown cause in Wuhan. And following that, another important event that actually recorded on the 13th Jan, there's a first confirmed case outside of China, which is happened in Thailand, in a traveler who has visited Wuhan. And another important date that we would remember, I think we already so-called celebrated the anniversary of the on the March 11, whereby the WHO declares the coronavirus outbreak as a pandemic. And these are actually the worldometer data, which actually recorded coronavirus cases. As for of yesterday, it recorded actually about 155 million cases with death of 3.2 million and recovered about 133 million. And where does Malaysia rank? It's, in the whole wide world, it's actually at the 42nd ranking after Morocco and before Saudi Arabia. So we actually already close to almost 500,000 with a death toll, another additional 17 as of yesterday. So just to get to know the virus. So the virus is SARS-CoV-2. So the disease is COVID-19. So this SARS-CoV-2 is actually a beta coronavirus. It is enveloped a single-stranded RNA virus. And what does this SARS-CoV-2, how does it penetrate to human cells? So with their spike of protein. So the spike of protein here will bind into the and it has a high affinity towards angiotensin converting enzyme 2, which is the ACE2 receptor, which happen to be throughout of our body. So commonly actually be found in the lung and also heart, liver, intestine, and also blood vessels. And the disease is actually started with the early stage in which once the virus attached to the ACE2 receptor, there's a cell proteins actually called serine protease type 2 transmembrane serine protease TMPRSS2 in the host cell, which actually help to further promote the viral uptake by cleaving the ACE2 receptor, and that activate the SARS-CoV-2 protein. And with the activation, it actually enable the virions to enter and release their RNA into the affected cell, and therefore the replication will begin, and there will be a translation into a new viral protein. So that's where the viral actually going to replicate. So in the early stage, the viral copy numbers can be very high in the lower respiratory tract. So therefore, as a host, we're going to react. So therefore, there will be an inflammatory signaling molecules that are going to be released by the infected cells, and the alveolar macrophage in the addition to the recruited T lymphocyte, monocytes, and also neutrophils. And the later stage, what happened actually, the pulmonary edema occurs, which therefore it will fill up the alveolar spaces with hyaline membrane formation, and this is compatible with the early phase of your acute respiratory distress syndrome. So these are the stages that the patient could have, especially in the patient who has a spectrum from coming in a milder symptom, going to move and progress to the severe infection. And acute COVID-19 actually can be last up to 4 weeks from the onset of symptoms, and beyond which replication competent SARS-CoV-2 virus has not been isolated. And post-acute COVID-19 by this paper actually defined as a persistent symptoms and delayed or long-term complication anything beyond 4 weeks. So the listed of ongoing COVID-19 symptoms are as what actually illustrated on this graph. So the patient may experience fatigue, muscle weakness, joint pain, and it can actually be a direct caused by the virus alone. And it could be also because of decondition due to the prolonged stay in the hospital. And because it's most of the time affect the lung, majority of patients. So the patient may have dyspnea, cough, and persistent oxygen requirement even after the disease has actually recovered. And some of the patient also may have psychology disturbance in which they become anxious, they become depressed, they have problem in sleeping, and they also have this what we call become blur or brain fog or cognitive disturbances, and very non-specific headache. And for some patients, they do experience palpitation, and this palpitation could be due to the pathological caused by the heart, or in fact also because of the anxious as well. And thromboembolism also being documented even during the acute event of the COVID-19. And some of the patients do progress from becoming a renal failure patient from acute to chronic, or it can actually exacerbate or progress a patient who has a pre-morbid chronic kidney disease, becoming an end stage later on. So in COVID-19 disease, so infection, when they're not just talking about merely infection, so they talk about cytokine storm. So the cytokine storm happen whenever there is an infection of this as a potential trigger or initiation, and this actually trigger all this inflammation signaling. So there is a biologic mechanism that actually involve multicellular mechanism to contain invasive pathogen and resolve injury by activating the innate and adaptive immune responses. So it is our body who responded to the virus, And some of the response is just adequate, and some of the response is perhaps over-exaggerated. And it depends on the host. If the host is immunocompromised, so perhaps the infection may take over the inflammation process. If the patient is an immunocompetent person, either they responded adequately or they over-responded, and also that could actually lead to a damage to the lung as well by inflammatory process. So from previous history of SARS, so they have studied in SARS period of time. So SARS also actually comes with the respiratory disturbances and sequelae. So in an acute event, acute stage that happened within 7 to 10 days, the lung actually demonstrates massive edema, high membrane formation, and all this description actually well fitted into your acute respiratory distress syndrome. And at the same time, with all this inflammation ongoing, fibrous tissue also try to set in the alveolar spaces. In the medium phase, whereby it happened within 10 to 14 days, so the lung actually try to organize in such a way it become fibrous and try to organize. So there are fibrosis in the interstitial and air spaces. And this actually involve the fibroblastic proliferation and the type 2 pneumocytic hypoplasia. And it can become more extensive with time. And this phase usually referred as a proliferative organizing stage. So it still proliferate and they still have some component of inflammation. Whereas at the later stage in which it occur anything beyond 2 weeks. So this stage actually becoming a fibrotic stage whereby the lung actually has a dense septal and alveolar fibrosis. So this time duration is actually counted from the onset of the symptoms, and the pathological of process may not actually have to go through all the 3 stages. May be cease or recover at any phases. So again, it depends on the host response. If it's elderly, sometimes they can have what they call immunosenescence. They become immune senile. And also sometimes they become inflamed aging as well. So in elderly, they will expect less response in which that they become, they would actually have more fibrosis as compared to the younger population. And does COVID-19 actually behave the same as what SARS did? So this paper actually looking at the whether this COVID-19 related lung pathology, whether it's in old patterns in a new clothing. So again, they still actually looking at the same pathological process. So from pre-exudative phase become exudative phase, and they organize the phase, and later on become fibrotic. And this happened within a period of time. This is a summary of a few papers that just want to highlight to you. So once the person get a SARS-CoV, so it depends on the host response. So whether the patient able to actually overcome the infection, and also what will be the immune response towards the infection. So at the level of alveolar capillary, there will be some alteration. So what happened is, one, due to the hyperinflammation due to the cytokine storms, so there will be a lot of elevation of pro-inflammatory cytokines, including the interleukin-6. So that's your anti-interleukin-6 treatment, which use tocilizumab actually works during this phase. So this could also happen in your pathogenesis in your inflammatory interstitial lung disease, whereby they also have a hyperinflammation phase, which include the same pro-inflammatory cytokines. And there's a dysregulation of release of proteolytic enzyme, and all these elastases and metalloproteinases are so much involved in a fibrotic cells formation. And besides that, there's also unregulated angiogenic responses through release of the VEGF and angiopoietin-2. And all these actually will become organization and become fibroproliferation, and with the formation of the provisional extracellular matrix. And this pathogenesis also is being described in a disease called idiopathic pulmonary fibrosis. So what happened in IPF, it follows almost the same. So now, whether the pathway goes into two. So in IPF, they go only one pathway, whereby the destination, the patient will become fibrotic and progressive fibrosing lung disease. However, in a patient with the SARS-CoV-2, which has a lung inflammation and complicated with the lung fibrosis, so they can go into two pathways. Either the host can able to actually resolve or remove the extracellular matrix, and therefore the lung actually resolve without even having a fibroproliferation sequelae. Whereas there are also hosts, like especially in elderly, male, and with comorbidities, and those who are smoker or former smoker, they could actually have a problem in removing the extracellular matrix. And therefore, they have a residual fibrosis with a pulmonary dysfunction. COVID-19 and lung. So the study in autopsy showed that a small cohort looking at the autopsy findings showed there are actually acute lung injury happened at histology findings, and primarily showing there's an exudative phase of diffuse alveolar damage, just what they have been described in the pathogenesis of SARS and also the SARS-CoV-2, the latest one. And there's also a minority displaying of organizing or proliferative phase. So what does it tell this? A patient who died and with the COVID-19, with a severe lung involvement, and with this histological pattern of diffuse alveolar damage, this is actually an acute respiratory distress syndrome manifestation. And they only see very minimal organizing phase. So organizing phase is actually a level or is a process of tissue repair. So there are also a description on organizing pneumonia. So organizing pneumonia in general is a term of a process of a lung tissue repair. So why I want to talk about so much on organizing pneumonia, because after this, the CT scan that I would show, they're almost all about OP pattern. So OP for the short of organizing pneumonia. So it's a process of pulmonary tissue repair, which could be due to either idiopathic or secondary to lung injury. So there are many causes of that can actually cause the organizing pneumonia. Histologically associated with pulmonary lesion of another nature, such as vasculitis, you can also find in lymphoma, lung cancer, hypersensitivity pneumonitis, and many more. And this one need to be distinguished between clinical and radiological features, because this will determine the prognosis. So it really depends on what caused the organizing pneumonia and what is the involvement on the radiology, and also the how extensive is involved the lung. Histological data may be helpful, but radiology is already good enough and utmost important, and with available clinical data to diagnose and organize pneumonia, meaning that you do not have to biopsy a lung just to diagnose and organize pneumonia. So these are the etiology of secondary organizing pneumonia. So one of the causes is actually infection, and viruses has been listed one of the causes to cause this OP. And we move on to how do we recognize a CT pattern on COVID-19 pneumonia. So there's a review on typical CT findings and some differential diagnosis. So the main features is always about ground glass. That is the first radiological encounter if you do his high resolution CT or contrast enhanced CT thorax on a patient with a COVID-19 infection. And the distribution usually typically peripheral. So the typical one is peripheral. So you will have some suspicion, if you see especially chest radiograph that happen to be, there is the opacity that located only at the periphery, and you have a patient with fever, I think if a patient, such patient present to your clinics, you would always think of COVID first until proven otherwise. And other radiological changes that can be seen, in fact, what they have mentioned are the linear consolidation. But there's also saying that it happened only after several days after the onset of the disease. But the first encounter would be the ground glass. So this is another paper that actually described patient in Wuhan. So they actually did for a patient even at stage 1. Even at stage 1, they're supposed to be asymptomatic patients. They still have a ground glass opacity. And I don't think so this can be seen on your normal chest radiograph. So a CT can detect and very sensitive to actually you can actually appreciate the changes on the CT scan. So in fact, at stage 2, 3, and 4, even you can see even different type of CT changes, not just ground glass opacity. You could actually see a reticular. Reticular, in a easy word to say, is actually a line. It's actually a septal line, or we call it a fibrotic line. And there are also some mixed pattern, and last pattern we would actually appreciate on a CT scan would be the consolidation. That consolidation is same as what you see in the other cases of pneumonia. So the role of imaging is not in doubt. So definitely there are specific role in doing chest radiograph especially, and to be precise, to get a chest CT to see all these specific pattern. So again, they still describe ground glass opacity as the commonest pattern that is found on the CT scan of a COVID-19 patient. So how does the radiology of organizing pneumonia looks like? So classic form, usually it comes as the name as a pneumonia, so you come as a consolidation, but it's actually multifocal parenchymal consolidation. It also can present as a nodular form, can be solitary and multiple nodules. It has also there is a pattern of a reverse halo sign, or they call it Ethel sign. Perilobular abnormality, this is commonly being described in a patient with the COVID-19 with organizing pneumonia. Bands of consolidation, crazy paving pattern, and also progressive fibrotic pattern. So I'm not going to leave you with all these worthy slides, so I'm going to show you the picture. So these are the pattern of organizing pneumonia that you can appreciate on a CT scan. So this is a pattern of perilobular density. So this is organizing pneumonia. And this is a pattern of a reverse halo sign, or they call it Ethel sign. And this is like almost a band consolidation. And some of it come with multiple nodules, or in fact is as a consolidation with the air bronchogram. Okay, so these are all the patterns of organizing pneumonia that has been described in many papers. So in terms of the stages, let's see, it really matters. It really matters when the decision of the CT scan and also the duration of the stage of illness. So if you do it very, very early stage, they call it ultra early stage. In this classification, actually described by Fatima in this paper. So just prior to symptom onset, so what can they found? They just found a multiple scattered ground glass opacity, very non-specific. So you really need a positive PCR to diagnose this as a COVID-19, not just the HRCT alone. At early stage, also they will see, we can appreciate a ground glass opacity. Sometimes it can be irregular, and interlobular septa begin to develop. In a patient with the progressive or progression stage, this is within a week of symptomatic presentation. So this is where the organizing pneumonia actually appear. So the CT finding would actually see a subpleural consolidation, there are some airborne programs seen, and there's also some irregular septa. At the stage of consolidation, so this is actually within 2 weeks of clinical symptoms. So there are also vascular congestion, and there's a fibrosis predominate. So there will be a decrease in size and density of consolidation, and you will see more reticulation, more fibrosis, but it almost similar finding of radiology as what you see in interstitial lung disease patient. And the last stage is dissipation stage, whereby this is more towards a healing and repair response within the lung. So what you could see, all the changes becoming more patchy consolidation. Sometimes they can have a reticular opacity, just like a strip-like opacity, and some can just presented like interlobular septal thickening. And this would happen across after 4 weeks of symptoms. So they are actually recovered from the COVID-19. And if you do a CT scan, you would appreciate all these changes. So in terms of involvement, how do they find the severity? So from Gouffran paper, actually they actually calculate according to the lobar involvement, and there are scoring system based on the lobar involvement percentage. So basically the scoring is actually full marks is 25. So anything score less than 7 considered mild severity. So always correlate with the clinical. And then in the middle will be 8 to 17, and anything above 18 and more is severe disease. And not to forget, besides the parenchyma changes, not just organizing pneumonia pattern or consolidation, COVID-19 patient also prone to get pneumomediastinum and pneumothorax as well. And this actually due to either due to the age, the more elderly patient. And from this small cohort study, they see more patient in age more than 50 years, male, and then especially on mechanical ventilation, surprisingly without any underlying lung disease and never smokes. However, in terms of the occurrence of the pneumothorax and pneumomediastinum in COVID-19, no difference in 28-day mortality when compared to the national average. We move on to the histopathology. So again, what happened to the lung, what COVID-19 does to the lung. So most of the cases come with the acute lung injury and acute respiratory distress syndrome, and they have the diffuse alveolar damage on histology. And other histologic pattern that can be appreciated are the acute eosinophilic pneumonia, acute fibrinosis and organizing pneumonia, EFOP. So EFOP is a very extreme, rapid, progressive lung injury. And last but not least is diffuse alveolar hemorrhage, also towards the end of the spectrum of the severe acute lung injury. And these are the histology images looks like when the patient is actually at the acute exudative proliferative phase. What you could appreciate, all the lymphocytes and the lung architecture is still almost preserved. Whereas in the diffuse alveolar damage is haphazard, it's almost congested, and you see all these are actually diffuse alveolar damage and organizing phase. So then later on there will be a hyaline membrane sets in, and it is almost never when it comes to this stage, it's almost always difficult or less responsive towards any treatment that you give. So this is at the stage of a late ARDS. So the difference, sometimes people got confused. So whether OP is equivalent to the organizing DAD or diffuse alveolar damage. So definitely it is not. Organizing pneumonia, if you see one, it is something like you can have there will be a chances of the patient actually get recovered. Maybe not to 100% normal lung function, but going to recover in terms of the lung function and also in terms of the radiological pattern. However, in a patient who develop organizing diffuse alveolar damage, if they survive, it's difficult for them to get recovered, and they will get secondary superimposed infection very easily and become deconditioning and maybe actually at the stage of requiring persistent oxygen. So in the patient who we catch has organizing pneumonia on the CT scan when in COVID-19 patient, they have intervened with the normal lung parenchyma. Means that the normal lung parenchyma still function as usual, but the other part of the lung get affected by the COVID-19 or that represent as an organizing pneumonia will be less function, but they get recovered and they get settled with the immunosuppressant treatment on top of the antiviral treatment given during the acute phase of COVID-19. So what are the immunosuppressant treatment that they have been recommended? So by ISDA or NIH, they mentioned about using dexamethasone, and that is about 6 milligrams per day for up to 10 days or until discharge. So it doesn't state exactly the exact dose and how you do it. So always correlate with the clinical of your patient. So it is recommended only for patients who require oxygen, who has a very severe lung involvement up to the extent required mechanical ventilation. They do not actually recommend it at all a patient without oxygen supplementation. So this paper actually by our infectious disease team group from Sungai Buloh Hospital. So they actually studied the clinical characteristic and risk factor for severe COVID-19 infection. Because we know that majority of our patients in the past, in 2020 per se, 92% of them actually presented with mild disease. When we talk about mild disease, perhaps they are in category 1 and 2, and maybe 3, 4 and 5 considered severe. And not many actually progress to severe disease in this, especially what has been described in this paper. So common complication that I've found, one of it is the acute respiratory distress syndrome, and factors that are associated with the severe COVID-19. As you remember from the pathogenesis that I showed to you, so elderly is one of the factors, and with comorbidities. And those patients with the abnormal chest X-ray, and especially those with the high C-reactive protein, means to tell you that there is a high inflammation process ongoing. So if you look at the table that describe the description on the patient that they have studied in this cohort of our patient, so they quite significantly showed chest radiograph abnormality that associated with the COVID-19 severity. And what have they found on the chest radiograph? So the abnormality that have been actually described or reported were ground glass opacity, consolidation, interstitial opacity, nodular opacity, and hyperinflation is not significant, but I guess this hyperinflation is a description. Maybe the patient has a concomitant emphysema as a comorbidities. So hyperinflation is not a typical radiology changes of your COVID-19. So we move on to post-COVID-19. So COVID-19 is not always a linear disease whereby you have an acute phase followed by a recovery or a steady state rehabilitation. It can be cyclical disease with symptoms moving around different body systems and fluctuating in severity. And because it's a novel virus, so we do not know so much about long-term health outcome of the COVID-19 survivors, I think. But of course, after a year plus, somehow we could actually see there are patients who actually has a debilitating and has a problem to recover from post COVID-19. And post-COVID syndrome, actually anything that developed during or following an infection consistent with COVID-19 that continue for more than 12 weeks. So anything that sustained more than 3 months, and you can't explain by any other alternative diagnosis, we could label them having a post-COVID syndrome. So when they look at the SARS COVID in the past. So basically, besides SARS, they look also at the MERS after hospitalization. So there are many studies looking at the lung health outcome, and in which they look at the lung function impairment, exercise tolerance, and quality of life. And which showed that at 6 months, the lung function still not back to normal. But after 6 months, some of the patient may recover. So it doesn't tell us details. So again, I think there are more research to be done to study on the sequelae of the respiratory following COVID. So there are many actually discussion or conversation, in fact, in the social media on the long COVID. So when they see this and they know that long COVID syndrome or post-COVID-19 syndrome can be something can give an impact to our healthcare in future. It can be also detrimental to some of our patients. And they actually make a phone conversation with the patient that have COVID-19, and those are actually treated as an outpatient. So after they recovered from the disease, and they ask whether the patient still have problems. So what have they found? Actually, there are many unresolved symptoms, and they found that the patient has a persistent cough and persistent fatigueness, and some of them have actually persistent dyspnea. So these are all the symptoms that pointing towards a respiratory sequelae. And another survey, and this is done in UK, whereby they did a survey on a phone application. So they found that many patients actually experiencing fatigue, headaches, cough, and also anosmia that could be persist even after 30 days after discharge from the hospitals. And also an analysis in a big group actually has about more 600 plus respondents, showed that more than 90% actually respondent had not recovered from many symptoms, very non-specific symptoms. So it's really pretty bizarre and actually not like our viral UTI type of disease. And again, from this paper, to highlight to you, so there are patients even after recover from COVID-19 and they get discharged, post-COVID-19 follow-up, about close to 90% still have persistent symptom, at least one, particularly fatigue and dyspnea. So these are more to like a deconditioning and also respiratory sequelae symptom. And from this paper, this is done in France, also noted that 2/3 of the patients actually experiencing dyspnea, and that's quite a huge number of patients still have a prolonged symptom. And they found that age 40 to 60 as one of the risk factors to have a prolonged symptom. And depending on the hospital admission at the symptom onset, if it's very late admission, from the symptom onset, they recovered from, they will have a prolonged symptom even more as compared to those who actually get admitted earlier. And patient who has a severe COVID-19 infection will have a prolonged symptom as compared to those who has mild COVID-19 infection. And other consequences besides respiratory that also involve, but they think is more towards the immunological manifestation, such as the central nervous system. They involve they could actually, patient could actually get Guillain-Barré syndrome, and they could also get a venous thromboembolism, not just during acute, but also after the COVID-19. And cardiovascular, they can actually have a cardiac arrhythmia as well. And some of the patients do actually complain of palpitation. And another symptom that may not easy to diminish, that is the cough. So they have also a patient of cohort of patient who still complaining of persistent cough. So this cough, they try to get they try to understand the mechanism. So sometimes because the chest radiograph actually when repeated during the follow up has resolved in terms of need become almost normal, but the persistent cough is the main concern. So they hypothesize maybe there are some neurological involvement that cause the persistent cough in a post-COVID patient. So whether or not we need to follow up COVID-19 recovered patient, is it really necessary once the infection settle? Do we really need to follow them up? But looking at all the manifestation that has been illustrated in many papers, they are not really well and they are not totally recovered. And at one point, they need someone to actually follow them up. So the question, is it mandatory? So it really depends on the local facility. So if let's say it shouldn't be the managing team of a COVID-19 during the acute infection who's doing the follow-up, it must be actually collaborated with another team of certain subspecialty who's going to do the follow-up depending on the organ that being involved. So there are many studies that actually looking at the long COVID disease. So they still recruiting and still ongoing. So we do not have any specific data apart from what I have actually showed you earlier. So besides that, they are also looking at the therapeutic measurement in terms of how to get the lung improved better after a severe COVID-19 infection, especially those who has fibrosis as a respiratory sequelae. So they're looking at many therapeutic agents, including the antifibrotics such as nintedanib and also pirfenidone. So whether in future, so this is a classification of interstitial lung disease. In general, we have about more than 200 that listed under this umbrella of clinical entity. So I don't know whether in 5 years' time, we may have a post-COVID-19 lung fibrosis being included in the interstitial lung disease classification. The time will tell us. So another thing about a patient who has who actually get a severe COVID-19 infection and complicated with the respiratory sequelae such as lung fibrosis. So whether or not they may trigger a new onset of interstitial lung disease. And another concern is whether they could actually developing idiopathic pulmonary fibrosis, because one of the risk factors associated with IPF is a chronic viral infection. So IPF occur in an elderly man, predominantly, and smoker or former smoker. So some of our patients who actually did not recover well has the same demographic data as what we see in IPF patients. So the follow-up, there are many methods, there are many ways to do it. So this is adapting from UK. So basically they divided into two categories. One with patient who actually discharged from ICU, another one is from a normal ward. So what they would do is actually telephone consultation within 4 to 6 weeks after discharge, just to see whether they are how they are being doing and everything, and then they do a holistic assessment besides just asking merely on the respiratory part. And 12 weeks after discharge, what do? There will be a face-to-face clinical assessment, which they will do chest radiograph, and they will consider a full pulmonary function test and a walking test assessment with the oxygen saturation. And depending on this finding, and we will decide whether the patient require a further imaging to decide whether this patient has a persistent lung fibrosis following COVID-19 or a persistent pulmonary vascular disease following COVID-19, because some of COVID-19 patients do have a COVID angiopathy and pulmonary embolism during acute illness. And this is another suggestion, and this is paper from US, actually suggested by, written by Ganesh Raghu. So they actually make it in a very comprehensive manner, in which again, telephone visits in first and 2 months, and then 3 months is in-person visits, whereby they do the same thing as what UK is doing. So again, the 6-minute walk test, and also subject a patient for high resolution CT to look at the whether the changes has resolved or become permanent. And long COVID, whether it can be actually seen in a primary care. Of course, again, this is a paper also coming from UK. They, as a primary care physician, they are not just looking at lung, they will look at holistic approach. They will look at every other aspect besides the pulmonary. So psychosocial aspects and other organ that may actually affected following COVID-19 infection. So the treatment for post-COVID or organizing pneumonia, they have not actually come with a strong recommendation. But what we've been doing following a dexamethasone of 10 days, or even metiprednisolone for a period of time, then the patient will be discharged with the course of oral corticosteroid with a tapering dose, at least about up to 2 to 3 months, depending on the severity of the disease. So besides that, for the respiratory sequelae, usually we will check whether we will assess whether the oxygen therapy is recommended, especially for patients with hypoxemia, and whether the patient require a VTE prophylaxis, especially those who actually has not been mobilized yet, especially those who are deconditioning following post extubation or prolonged hospital stay. And they advocated and they strongly recommended to integrate rehabilitation along the way, or along the recovery of your post-COVID-19 patient. So rehab is one of the in thing. So these are actually especially for respiratory, so especially for patient who has breathlessness even at rest and not improving, but the X-ray is improving. So this is what they call deconditioning, and the muscle becomes sarcopenia. So we need to rehab the pulmonary part to regain the exercise capacity as much as we can, maybe to the extent as where they are before they get the COVID-19. So the last few slides will be on cases. I'm just sharing the cases that we have been followed up in our institution. So we have various encounters. So we have a case with a persistent fibrosis post-COVID-19 that eventually we diagnosed him as an idiopathic pulmonary fibrosis triggered by the COVID-19. So this is 73-year-old man, former smoker. So this demographic tells you that he is in the elderly and has comorbidities. I mean, who was a former smoker. So he was intubated and extubated, and then was discharged and then re-admitted because of breathlessness on exertion. And he was actually, the oxygen saturation was, he was not hypoxic, but he felt breathless. That's why when he walked, he tried to limit himself. And his FVC rate at 51%, which is moderate respiratory restrictive ventilatory impairment. So when we look at this chest X-ray, this is when he had his first chest X-ray when he had the acute illness, and following which this is before he was discharged. So, and this is on during a follow-up in our institution almost 2 months after COVID-19. So why I actually make this line is actually just to highlight you. So the diaphragm usually will be, the right diaphragm will be higher than the left. So this one is the other way around. So it's not dextrocardia. But just to tell you that there are reticulation, nodular reticulation on the left lower lobe here, which indicate fibrosis. So when there's fibrosis means that there is a volume loss. That's why the diaphragm has been pulled up higher as compared to the right. So you could see the hemithorax of the left lung is smaller as compared to the right. So when we look at the CT scan, this is at the 4th week of illness, and this is about 2 months after the COVID. So these are all the linear so-called consolidation. But apart from that, you could actually appreciate also some perilombular density. So this perilobular density is acute phase during the acute phase of illness. Even though this patient has at 4th week of illness, he still have the acute component of organizing pneumonia. Means that the host is unable to clear all the extracellular matrix and all the extra cytokines from the system. And all this opacity actually become even more fibrotic on the follow-up CT. So what you could see here, bronchiolactasis changes means that airway that actually being retracted, small airway has been retracted because of the fibrosis. And the volume of the lung is actually reduced because of the fibrosis. So another one is a case with the comorbid bronchial asthma. So again, bronchial asthma, a patient who she is 49, non-smoker, bronchial asthma on treatment, COVID-19 positive, but intubated actually for asthma initially for 1 day, and then later on discovered that her PCR was positive. However, she has a problem in a recovery. So 3rd week of illness, desaturated, and showed that there is a new patches on the chest radiograph, and on the CT scan showed there is organizing pneumonia at 3rd week of illness. So all these are perilobular pattern, and these are all clearing up by the prednisolone that she was started on. So these are after 6 weeks after discharge, after given course of steroids, and the chest X-ray become better, improving, and she started to work as usual, no cough and no breathlessness. But if you look at the lung function, it's still not recovered, even though she has no symptoms anymore, and she started to do her routine activity. And her 6-minute walk test, she has some desaturation as well. And this is a patient who actually at middle age, former smoker, no comorbidities, category 4 COVID-19, highest oxygen requirement on high flow nasal cannula. And upon discharge, he was very breathless on exertion and cough. He was an active person before he got his COVID. He completed a course of steroid, even having said that he did not recover well in terms of the symptoms, so we subjected him for pulmonary rehabilitation. So he was warded and had 8 days with 8 sessions of inpatient pulmonary rehab. So after about 3 months, the follow-up CT, so this is during the acute illness. And in November 2020, like after 4 weeks of discharge, when we do his lung function test, the FVC read as moderate restrictive ventilator defect. And on follow-up CT after almost 3 months, so you see the straight line of a consolidation or even straight line of fibrosis, means that it's recovering. And you look at the lung function, it become normal. So organizing pneumonia, there is a potential of reversibility in COVID-19 patients. So these are the tools that how we actually assess our patients: 6-minute walk test and lung function test. This is our rehab, so physiotherapy team before COVID time. That's why there's no social distancing. And these are our patients. So I've taken their picture with their permission. They said can be shared with the rest of participants. So these are the patient that actually being warded just mainly to do an inpatient pulmonary rehab, and they recovered from a COVID-19 category 4A respectively. And this where he was intubated. He's a patient of mine, follow up for autoimmune related interstitial lung disease on immunosuppressant. He has problem in weaning off oxygen. When he was transferred from Sungai Buloh to our institution, he was on 7 liters of oxygen. He was discharged after 56 days in our institution. He was in Sungai Buloh close to 48 days. So in total about 90 plus days, almost 100 days. And discharged with 1 liter of oxygen. for the time being, the latest update, he require only PRN basis of oxygen. He able to walk as many steps as before. At this present, when he was discharged, he could only walk about 10 steps with a walking frame, and now about 80 steps without walking frame. So our local experience, so we have seen about total of 176 patients. So majority are at the middle age, predominant men, and majority are Malay. So patients who are referred to us with the CT findings of organizing pneumonia. And if you look at the follow-up spirometry, this is roughly about after 4 to 6 weeks discharge. Majority of them has a respiratory impairment still. And in terms of the post-COVID-19 functional status, there are proportion of patients who has a grade 2 and above. So how do we grade this? This is according to this paper. So basically grade 0, no functional limitation, grade 1, negligible functional limitation, grade 2, slight, grade 3, moderate, and grade 4, severe. And we do have a proportion, small proportion of patients still in grade 4, and this need and comprehensive, extensive rehabilitation. In conclusion, COVID-19 can result in prolonged illness and persistent symptoms, even in young adults and in person with no underlying medical condition who were not hospitalized. Although the one that has been described, those are elderly and also with comorbidities. More time and research is needed to understand on the long-term effect of COVID-19 on the lung, whether the symptom persists or recur, and how this health problem affect the patient and the clinical cause and likelihood of full recovery. Thank you for listening.
My apologies, just hold on for a while. Okay, thank you very much, Dr. Syakirin, for the comprehensive talk. Now, we have a lot of questions here. Let's go one by one, but we have time limitation. So maybe you have to answer them very concisely. From Dr. Kamala, after an attack of COVID in group 4 or 5, after recovered, can they get lung CA in the future? Lung cancer, the first question.
Lung cancer in the future, post-COVID-19.
Yes.
I don't think so. I have found any paper actually documented that. But if they have a persistent lung fibrosis, there is a chances of them developing lung cancer in future. Right. If they have a persistent lung fibrosis.
Yes. Okay. From Dr. Lai, how long typically a non-COVID organizing pneumonia will resolve without treatment? I think you answered this in the talk. You want to just give a brief one?
So without treatment, it's difficult to say. But with treatment, I think we will see, it depends on the severity. So we will see about close to 2 months after 2 months of treatment of steroids. Usually when we taper, it's within 2 months. So the dose of the steroid, unlike that what we do in organizing pneumonia, interstitial lung disease, like what we actually do in cryptogenic and autoimmune related, that require even higher doses of prednisolone. But for post-COVID, after following parenteral dexamethasone and methylprednisolone, so you go by 0.5 to 1 milligram per kilo a day, but maximum just go for 60 milligram prednisolone a day, regardless of the weight. If the patient overweight 80, you don't put 80 milligram pred, you just put cap 60 milligram and you taper every 5 days, 5 milligram, and taper it down and off.
All right, the next question, OP and DAD only can be differentiated with histology, or is radiological enough?
DAD is a histological description. So there's no way that we can actually tell DAD from radiology. However, the clinical manifestation is ARDS. the end spectrum of your acute lung injury. That can tell, I mean, theoretically, the lung histologically, they are DAD ongoing.
Okay. The next one is asking whether the role of antifibrotic in post-COVID ILD.
They are still investigating. I think they're still recruiting patients. The study done by Vincent Cotin in France, I think Pirfenidone is in US. So far, I have not heard any preliminary results yet. But from our small cohort of patients, about 176, only one that has been prescribed on antifibrotic because of the development of becoming IPF. The IPF has been accelerated by the COVID-19, not as per indication as a COVID-19 lung fibrosis. If you are giving out of indication, bear in mind, you must get an approval from DG. And the funding is a bit difficult. Right? It's not a cheap drug. You can ask my pengarah on that.
All right. The next one, what is the role of primary healthcare in managing patients with long COVID? Any indication for referral to respi team? Normally, what will be offered by respi team? I think you have mentioned it, but maybe briefly.
Okay. The role of primary care physician is to follow up, and if there is a persistent symptom and persistent chest radiograph abnormality, there is a need to refer to the tertiary center. It can be to the general physician or to the respiratory. It doesn't have to be a respiratory, solely respiratory. So from what we do is actually what we advocate, what we subject our patient, we will do pulmonary rehab. And if let's say there is a persistent opacity on chest radiograph, we will actually schedule the patient for the high resolution CT, and depending on the finding and treat accordingly. If there is a persistent organizing pneumonia we can't explain why, there's still a role of giving a steroid even after post-COVID-19. But we need to discuss in a multidisciplinary meeting because it's not really commonly seen.
All right. There's a question that for those with a COVID infection group 3 or 4, when can they get their vaccination? Whether it is immediately or you have to wait for 3 months?
I think the theoretically is 3 months after 90 days.
Okay. Right. Okay. Another one is, okay, I think this one is there any role of short course of MDI budesonide in COVID pneumonia management?
Okay, I forgot to touch on the development of hyperactive airway, because some of the hyperactive airway do actually develop following a viral infection. And yes, we do prescribe inhaled corticosteroid for patients within short period. But don't be surprised. You might actually diagnose undiagnosed asthma before following COVID.
Okay. The next one, for children or teenagers getting COVID, do they get worse or have they sustained long-term lung damage? I think most of your patients are elderly, right?
Yeah, our patients are elderly, Dr. Yati. So teenagers, we have not many teenagers patients. I do not have any children, pediatric age group of patients. So ours are mostly elderly. But I know that pediatric are mainly, they have immune type of manifestation, like they more towards developing Kawasaki syndrome as compared to what we see in our adult patient. But of course, I won't comment on that further because I do not encounter that group of patients.
Right. Okay. The next one, if a patient was diagnosed COVID-19 3 months ago, had a repeated swab PCR positive after 3 months, swab was taken due to recent COVID contact, do we treat as post-COVID infection or reinfection of COVID-19?
So I guess it depends on the CT value. So you have a PCR and depends on the CT value. So the CT value will tell us whether reinfection or delay viral shedding, I guess.
Okay. The next one, how long duration of steroid therapy for management of severe post-COVID pneumonia OP? How do we taper down the steroid regimen? Any benefit of steroids on the AD? I think you have covered this in your lecture.
Yes.
Okay, so we will dismiss that. Right, in Tawa, we noticed patient recovered quickly when given IV tocilizumab early. The tocilizumab is given before patient gets intubated. Patient also requires shorter metopred and lesser dose. In terms of steroid tapering, any difference than current suggested dose?
So if you have someone given metipred, usually I would suggest to give oral prednisolone and tapering dose, because you can't just off metipred and then without any tapering dose of steroids. But you could go by 0.5 milligram per kilo a day, which means that a lower dose as compared to the one without receiving tocilizumab or high dose of metipred.
Okay. Okay, Dr. Kwa Hani is asking when to use metopred instead of Dexa.
Okay, I think the first line would be dexamethasone. If let's say after increment of the Dexa dose up to 20 milligram, the patient still deteriorate, then we go for IV metipred, 1 to 2 milligram per kilo a day. And these are the dose that has actually been recommended by WHO, and also I think NIH also actually recommending it. However, there are patients who require higher dose of metipred. These are only on certain patients that has a CT proven that showed fibrosis. So sometimes what they call as a rescue therapy. So there are CT features that actually being described as if you have a patient that has a central fibrosis with corrugated airway with dense consolidation, especially when they have the disease, the stage of illness after 2 weeks of onset of treatment. There is a role of rescue high pulse metipred, but we do not actually advise to give high IV metipred at first instance. So it's always go by the lower dose first, because it's just to settle down the immune hyperinflammation phase that has been produced by the host. It's not by the COVID.
Okay. And one is asking, you have already answered how long and everything, but what parameters can we use to taper down the steroids while in ICU in ventilated patients?
Usually we go by, if let's say ventilated patients, so we look at the ventilator setting and the PaO2. And sometimes chest radiograph is not really helpful because they have radiological delay, number one. Number two, they may have a superimposed infection. So it's really hard to tell sometimes. But your justification, especially when you're able to wean off or wean down your ventilation support or your oxygen support, it tells you that that is the time that you should actually taper your steroids.
Okay, the next question, what further management should we give patient if patient post-COVID syndrome have prolonged cough and fatigue, or chest x-ray normalized, all workup for other diseases normal?
I would work up for the other diseases such as undiagnosed asthma or COPD. And then for the fatigue, usually we will subject the patient for the rehabilitation. That will help a lot. But it doesn't actually have an instant result, but patient must have a consistent and be persistent in the program if they've been scheduled one.
Okay, they are asking about the CT value, but I think you have answered the repeated whether it's reinfection or whether it's just post-COVID infection. So I would dismiss that. The last one, what is the rationale of discharge with oral Dexa, then continue with oral PrEP?
So there are patients who actually been discharged either Dexa or prednisolone. There's no wrong on doing that, but again, it depends on the involvement of the organizing pneumonia. So if you look at the organizing pneumonia, but in Sungai Buloh, they have the stages. They can actually tell us the severity, whether is it mild or moderate or severe. So in other places, maybe there are some limitation. So sometimes we go by the severity. If let's say the more severe, we would like to actually put the patient on longer term of a steroid, then I would go for prednisolone. If it's just a very mild organizing pneumonia, and the patient does not, does not actually require oxygen for many days in the ward, then I think we just go by dexamethasone and we just off.
Okay, the last one. Do you advise for pneumococcal and also flu vaccine in post-COVID?
Post-COVID patient, if they have the lung sequelae, yes, I would. And if they have a new respiratory disease being diagnosed, yes.
Okay, this is the last one I'm going.
Okay.
When can a patient after COVID infection go for elective surgery safely?
Post-COVID,
when elective surgery, when can they go for the surgery post-COVID infection?
so post-COVID in general or post-COVID with a lung problem?
It doesn't say. Maybe I guess it's with all the lung complications.
So if it's a lung complication, it depends on how bad is the lung get involved. So we really can't tell. So, and again, it depends on the urgency of doing the operation. If it's an emergency, then you will have to be doing it under high risk consent. If something that can be electively and can wait, then you might want to get the lung to recover first.
Yeah. All right. Thank you very much, Dr. Syakirin, for all the questions that you have answered. They really actually asked you a lot of questions. So I think I'll pass back to Dr. Mina for the closing. Thank you very much.
Thank you. Thank you, Dr. Yati. Thank you, Dr. Syakirin. Thank you so much for your patience and answering all those questions. Thank you very much. For all the participants, so for those who have not given the IC number during the registration, please message Academy of Medicine Malaysia privately. And then for those who would want to claim NSR CPD, you can use the event ID that I posted earlier. And the recording will be available in YouTube. If you missed a few slides, you can go back and have a look at it as well. Okay, thank you very much, everyone. We'll conclude now and see you again the week after next. Thank you. Bye-bye.